neurological and endocrine disorders. So emergencies that affect the nervous system and the endocrine system. Now, I only drew up a few different categories here, and that there are a lot more categories that should be put up on the board as far as anatomy and figures. So let's just review what I showed here. So we have the central nervous system. Central nervous system comprises of the brainstem, and the spinal cord. So we have a small little diagram of the brain. The frontal lobe is here. This would be your more anterior placement towards the front. And then we have this back area, the posterior aspect of the spinal cord. This is just a half view of it. Frontal lobe. This here, just outside along the side of the head, is the temporal lobe. The parietal lobe makes up the top superior surface. Here we have the occipital lobe towards the posterior side, and then the cerebellum. Each part of the brain having a small little difference in how it functions. Like here's some concrete thought. We have some speech pattern recognition, speech capabilities, both the frontal, temporal, and then the parietal is usually for our motor cortex, so to help us to move. Occipital is sometimes for vision. Here we have the cerebellum, grossly it's for equilibrium and fine motor skills. And then the vegetative functions, the stuff that when they say somebody is maybe brain dead, this spinal cord right here keeps them alive just to breathe and have the heart pumping. But their cognitive effects are pretty much shot because the brain is no longer functional. So here, the vegetative functions in the brainstem allow us to breathe, maintain adequate blood pressure, and so forth. How does this work? Well, if we take this spinal cord and I cut it, and I then rotate it this way so that you could see where I cut through, we have the spinal column. And it basically has these axons, and all of the cell bodies all line up. These things then send signals out and signals back to the nervous system to affect something. So there are signals, sensory signals that we feel, that are sent back into the brainstem, the spinal column, and then to the brain. And then from the brain, it goes back down to the spinal column, and impulses are sent out for a motor effect. So in the case where maybe you've done a reflex test where they strike the kneecap area, and you sense that it triggers a reflex arc that goes up to the brain and then comes back down, allows the knee to kick forward. Same thing if you were to touch a hot plate. You feel a hot plate or a flame, you know that it's sensing that you sense it's hot. That signal pain goes back to the brain, causes a reflex to have the hand withdraw itself from the external source. Now, this brain has its blood supply through these carotid arteries and the vertebral arteries in the neck, and they form this large circle of Willis that allows extra blood flow, what we call collateral blood flow, to service and supply blood to the entire brain. All right, so that's important. If we have a blockage in these arteries in the neck, or in the vertebral column, or they clot and block off a major artery inside the brain, we'll have what's called an ischemic or embolic stroke. Embolic stroke. So one of the first neurological emergencies we'll talk about is the CVA, or now known as the stroke. And stroke is time sensitive in that we need to get them to the hospital so that they can receive these clot busting drugs. So these are the guys that when we deal with them, I want you to be able to recall verbatim what is a lapse positive stroke, because we're going to identify that those things, and we're going to notify the hospital that this is a lapse positive stroke so that they're a good candidate to receive thrombolytic therapy or clot busting drugs. And this is Los Angeles pre-hospital stroke scale, where they were walking previously. They have no seizure or no deficits prior to this. They're not a diabetic. They're not very old in age. Right? They're never wheelchair bound. And then they don't have some of the other signs and symptoms: facial droop, slurred speech, hemiparesis, or arm drift. These other neurological symptoms or neurological findings that we'll use will be deployed by using a neurological exam where we check orientation, name, date, and place. Check the pupils for pupillary response and that they should be pearled and that both eyes react the same. Speech should be cleared. There should be symmetrical face grimace, that there's not a droop on one side. that when we have them to squeeze our fingers, that we have strong grip strength. Also checking the pulse and sensory. Can you feel this? As on both sides as well as the lower extremities. We're going to check pulse, motor, and sensory. So once we do our neurological exam and we identify the lapsed positive stroke, we want to call ahead. Again, this is a blood clot that has been dislodged and obstructs somewhere the cerebral blood flow or the blood flow that's going to the brain. There are many different types of strokes, not just the embolic stroke. There could be an aneurysm where a blood vessel ruptures and breaks. There could be a blood vessel where there's enough plaque that develops and it slowly occludes and blocks off that artery, thrombus. Or the one, like I said, it floats around in an embolic stroke. And that's the ones that we can use are clot busting drugs. I drew over here the endocrine system. Only endocrine organ that I'm showing you here in part of the GI system is a pancreas. Now we have other endocrine systems, and basically they have this type of pattern where they stimulate and send a signal up and a signal back down, and they send the signals up and back down, and when the signal is enough, then it'll terminate the signals from stimulating a response. So there's a negative feedback system. For example, some of us may have or live on what's called a catchment system. So eventually, as the bladder in your catchment system gets lower and lower, the pressure builds up less and less, and so it senses it and needs it to fill up. So the pump goes on to fill the catchment tank up. As that pressure tank builds up, a signal tells the system to shut the pump off so that we don't overinflate the bladder and break it or work so much that the motor dies out. Right? So there's an on and off switch. When we meet that requirement, it turns up. In this particular case, dealing with the pancreas, there are two endocrine hormones, insulin and glucagon. One helps sugar to enter into the cell, called insulin, and the other one stores it to be used later. In the case that we're talking about, there are two different types of endocrine disorders. I'm going to put down hypoglycemia and hyperglycemia. And this two conditions are very different. This means low blood sugar condition as a result of this not working. And this is high blood sugar condition as a result of this, again, not working. So the organ that's affecting the blood sugar levels is the pancreas. So a person might say that I have diabetes. I may be on a pill form, or I may take insulin where my pancreas no longer secretes insulin at all. If they're on the pill form, it may be that the insulin is not working well, or they just need more stimulus so that the insulin can work better. Anyhow, they would tell you that they're diabetic. Hypoglycemia is the condition where there's an overabundance, too much insulin. There's so much insulin that it ate up and used up all the sugar stores. And so now there's no sugar for metabolism to occur. The energy that we create cannot be occurring because there's nothing to burn. There's no sugar stores to use. So you have too much insulin, causes the depletion of those sugar stores. The patient becomes hypoglycemic. Too much insulin. They look pale, cool, and diaphoretic. They have an acute onset. It starts all of a sudden, they become disoriented. Again, they should be taking insulin and they had too much, or they had too little food. They didn't eat their meal when they took their insulin, so they didn't have that carbohydrates that they needed. So their sugar level is really low, an acute onset presentation. They become pale, cool, and diaphoretic. They're wet, skin signs. They're altered mental status, and then they should tell you that they have diabetes, DM, diabetes mellitus. On the opposite side, where they have hyperglycemia, let's go ahead and just say they have too much what? Too much food or sugar. That's correct. And they have little insulin. This is slow. This is a slow process that takes some time. The patient is not wet. The patient is hot, dry. And sometimes they complain of 3 P's. So the difference is it's starting to expand and it's easier for us to see. But then let's go back to the 3 P's for hyperglycemia. Too much food, too much sugar, little insulin. Their skin is hot, dry, and they have this 3 P's. Polyuria, increased urine production. Polydipsia, increased thirst and drinking fluid so that they can keep diluting the sugar. And polyuria, an increase in urination to get rid of the over sugar production that's in their bloodstream. These are all part of what's called an altered mental status type case. 1, the central nervous system. Here, the neuroendocrine system. We go back to what's called AIU tips, are a very large bag of other possibilities: alcohol, epilepsy, insulin, overdose or oxygen, hypoxia, uremia, trauma, infection, psychiatric disorders, and stroke. Now, there are many different other words that you can use for this acronym, but basically they're part of the altered mental status cases. And in the BLS nature, do a good exam, provide high flow oxygen. We're always going to check a blood sugar level on both of these cases just to make sure that they're not the same, because a diabetic patient can mimic a patient suffering from a stroke.